everyone. I'll get started then, unless. So tonight I'm going to talk about an approach to meningitis in pediatric patients or small humans, and I'm going to try cover just some basic principles that I think are important. But at the end, any questions, any comments are welcome. And it is a bit weird speaking to an empty room, as I'm sure you guys all know on Zoom. So yeah, feel free to jump in if I'm going astray or something. All right, so what I'm going to cover today is what is meningitis, what does it do, where does it come from, how these children and infants can present, what investigations can we do to diagnose, the management and complications, and then some references and questions. So firstly, what is it? Quite an easy definition, I think, is that it's an inflammation of the meninges. And I'll show you a picture in the next slide of what the meninges are. And classically, there's a triad of fever, headache, and neck stiffness. But as I'm sure a lot of us know, and as this presentation will kind of elucidate, is that in children, that's not a classic triad. There's nothing classic often about how they present. It can be very obscure and very vague. Some interesting stats in epidemiology is the WHO in 23 described sub-Saharan Africa as an African meningitis belt because of our high incidence of a higher incidence of meningitis as compared globally. Their stats stated that 1 in 6 patients die, with 1 in 5 having serious complications of those that survive. And this is for adults and children, that there's overall a 5% mortality rate, and then a long-term morbidity and delayed mortality of about 30%. So quite a high burden of disease in the world and in sub-Saharan Africa. Our South African stats, the latest that I could find in 2018 of a pediatric kind of relevance, is in 4 in 100,000 children and 40 in 100,000 neonates are affected by meningitis or diagnosed with meningitis. So also a fair amount, given that we see quite a lot of children, and it's a high proportion of our population in South Africa, children, I mean. So the meninges are the 3 layers that just very quickly surround our brain. The dura, arachnoid, and pia mater. Interestingly, for some, maybe the Latin origins of the words. I'm not really sure why mother, hard, and tender. I think the spider relevance becomes from the bridging blood vessels and look of the subarachnoid space, but just an interesting FYI. Then so infected meninges on the right-hand picture, you can see the subarachnoid space is swollen as edematous, has a lot of compressive features, which is responsible for a lot of the translocation of the organism, and the results that we find in an LP is because of that leakage and that change in the blood-brain barrier. There is, I think, we know about encephalitis as a separate entity, which is specifically infection of the cerebrum, but meningitis is specifically those 3 layers that become infected. And then there are combinations thereof, which would be a meningoencephalitis, but we won't go there. So what are organisms that are typically responsible? So it is, there's a separation between ages, that younger ages, so neonates up to 3 months are more susceptible to E. coli, group B streptococcus, and listeria. So I'll just check the chat. It's okay. Sorry. And the E. coli and the group B strep is usually as a result of labor, pregnancy-related complications, vertical transmission. And then listeria is a pathogen that often affects at extreme of ages, at immunocompromised individuals, and nutritional alcoholic sequelae or advanced alcoholic or nutritional diseases. And in your older kids, then your strep pneumoniae, Neisseria meningitidis, Haemophilus influenzae, and then to TB are more common. And that's quite a similar picture as for adults. And this is just in terms of the bacterial causes of meningitis. Interestingly, our vaccine schedule in South Africa has done really well to drastically reduce the incidence of Haemophilus influenza and to a slightly less extent strep pneumoniae. So we have quite a robust EPI, our expanded program of immunizations, which I have a picture later on where describing our EPI and the vaccines, our PCV for pneumococcal and our HIB for Haemophilus influenza type B. So the bacterial meningitis are less common in terms of incidence, but usually clinically more severe, whereas our viral pathogens are more common, but clinically less severe. You can see the list of viruses from the 3 months to adult, herpes, enterovirus, etc., with mumps, measles, varicella, and rubella also having been decreased quite a lot by our vaccination schedule, which is great. Then to a lesser extent, and I just touched on it briefly here, fungal and parasitic, and these are more, not as common, but are more common in immunocompromised patients for whatever reason, cryptococcal and neurocysticercosis being ones that we see not infrequently. So how do they spread? Well, on the left there, sorry, it's a bit of a busy slide. On the left there is described sites of colonization. So usually these pathogens could exist as normal commensals or colonized in those areas, but in an asymptomatic patient. And this can include on the skin, the nasopharynx, the respiratory tract, the genitourinary tract in pregnancy and labor, for example. And then is usually spread, 3 major pathways have been described, either hematogenously, retrograde spread neuronally, so say in an otitis media that then extends, or direct contiguous spread, such as like in a sinusitis, for example. So typically a child, or if they can talk and complain about ear pain, coryza, cough and cold, they could just, it looks like they just have an urti or sinusitis. This organism, if it is one of our organisms of concern, can spread into the CNS by one of those 3 major pathways. This causes this causes inflammatory mediators to respond to this antigen. So your cytokines, interleukins, chemokines, all of those myriad of things, which then cause all of this response, this inflammatory response, causes vascular endothelial injury to the blood vessels in the subarachnoid space, causing a increased permeability of a blood-brain barrier, and then entry of what would normally be kept in the blood into the subarachnoid space and into the CNS. There's also an increase in vasogenic edema, as we saw in that photo, as well as an increase in CSF protein. And then migration, as I've mentioned, of a bunch of other normally only located in the blood cells. They then migrate into the CSF and gives us our typical LP results of a higher protein, perhaps the organism, erythrocytes, and that kind of thing. So in terms of clinical presentation, these 2 long lists are probably not exhausted. There's probably more, and sometimes, especially in infants, they can present very vaguely with very subtle symptoms, such as just a change in the tone of their cry, for instance. But any changes in temperature, any concerns about glucose control, lethargy, apathy, irritability, more importantly, seizures, bulging, fontanelle, posturing is more, those are more significant signs in infants. And then as children get older, they tend to present more like adults. So more with your fever, your headache, neck stiffness, photophobia, and then they can actually talk. So you can ask them about these things as well. And again, seizures are quite a significant sign. Rash is also a significant sign, which I'll come to later, and that's our hallmark meningococcal rash that everyone's very nervous about. But ultimately, meningitis in most children and infants causes increased intracranial pressure. So any features of intracranial pressure, increased intracranial pressure, one must have a very high index of suspicion for meningitis. So that box there just describes signs of increased ICP, specifically headache, vomiting, posturing, eye signs such as decreased visual acuity or abnormal pupillary reflex, cranial nerve palsies or papilledema. But good luck trying to do a fundoscopy on a crying infant. And then Cushing's triad, which is again is something's described a lot, but I don't think anyone sees it as often as it's described. It's much more in textbooks, but that's hypertension, bradycardia, and irregular breathing flatten. I mean, we do see it, but it's mostly more like a pre-terminal sign. Yeah, so that's our presentation. Next is just another kind of picture about presentation, just to reinforce some of the signs in an infant. Because they can't speak, you have to do a lot more kind of clinical assessment, and then also remembering that the clinical presentation depends a lot on the age of the child, the severity and the process in the disease that one is at, and then the organism itself. Like I said, bacteria usually much more severe, viral a little less severe, etc. And then your cryptococcal and your parasitic infections are normally slower, more indolent, over a longer period of time, but not as acutely severe, such as like bacterial meningitis. And then this is just some pictures to describe this rash, the meningococcal rash that is quite typical. So it's a non-blanching rash, and a lot of texts talk about the tumbler or glass test, which is basically just pressing it and seeing that it doesn't go away, that it's a concerning petechiae. And there's quite a range in how it presents. The top right is very small, very pinprick, and then coming around to the bottom right, where it's a lot more purpuric, almost bruising and ecchymosis in nature. But importantly with this rash is to remember that it's a late sign. So it presents, it occurs late in the onset of disease. So if you're already seeing the sign, it's a medical emergency. And this child is already very sick by this point. And then in terms of investigations to get to a diagnosis of meningitis, so once you've had your high clinical suspicion of a child with these signs and symptoms, our NICD, the last guidelines I could find in 2019 of meningococcal meningitis specifically, but I think it applies to kind of all meningitis cases until proven, which organism it is. But the two called kind of hallmark means of investigating is a culture of the organism, either on blood or CSF, or DNA by PCR assay on blood, CSF, or constituents of blood. This is obviously dependent on your institution, whether you can do PCR assays, etc., and then also dependent on the clinical state of the child. For example, when it comes to a lumbar puncture, there are some contraindications to lumbar punctures, which I'll come to in the next slide. If you do get a lumbar puncture, though, what the NICD advises you send for is protein, glucose, cell count, gram stain, and culture. Those are the top. Thereafter, fungal studies, viral PCR studies, TB, which would be gene expert, and PCR and culture potentially, and antibiotic susceptibility is more dependent on case-by-case basis, and then also your kind of resource availability wherever you are. And then your blood tests are as appropriate to any sick child that comes in. I didn't want to go much more into that, but like gas and FBC, UNE, LFTs, CRP things. And then the cultures are very important here, because if you can't culture it on the CSF, you can try culture the organism on the blood. CT, brain, and MRI also good means to investigate. One, if an LP is contraindicated, and two, if you're looking for any other causes of raised intracranial pressure or abnormal neurology in a child. Also very resource dependent. And then other investigations to do that are not directly related to diagnosing meningitis, but fundoscopy and an ENT exam can help you isolate or differentiate between meningitis potentially, or a sick tonsillitis, or a sick epiglottitis and that kind of thing. And then the swabs, so nasal and throat swabs, interestingly, could help to also diagnose in such that you could isolate the organism on those swabs if you can't get a CSF culture or a blood culture. Just something to keep in mind if you have available resources and things. So contraindications for lumbar puncture. So this algorithm is taken from a 2013 paper, so a bit old, but I think it still applies, and it's relevant because it's a South African-based team. A couple of pediatricians who actually work at Rahima Musa were involved. So basically your contraindications for LP would be a reduced level of consciousness for an unknown reason. I like to think of it because it's difficult to check for papilledema in children. So basically any signs of raised intracranial pressure, I think I would have a high index of concern not to do an LP. A child with a VP shunt, don't touch them until neurosurgeon, I think, is involved. And then any unexplained seizures or new focal neurodeficits. So if you can't do an LP, then you don't delay antibiotics or treatment. You do a blood culture or any other kind of cultures you can do, and then get antibiotics started as soon as possible. Thereafter, get a CT brain as soon as possible. That can then determine if there's any radiological evidence to preclude a LP. If not, do an LP. If there is radiological concern, don't do an LP, but continue antibiotics. Interestingly, if they aren't, so that top box, those are your neurological contraindications, more absolute contraindications. But coming down on the no arm into your non-neurological contraindications, which are more relative contraindications, such that the text describes so severe cardiorespiratory compromise and abnormal bleeding are not contraindications in and of themselves, but it's more advised strongly to correct those before LPing. So, for example, if a child is shocked and cannot even sit or position themselves for an LP, don't do the LP until you sorted out the shock. Or if they have signs of abnormal bleeding, like bleeding from the gums or drip sites or from the nose that you can't otherwise explain, have a high concern for a clotting disorder, don't LP them until you get your clotting profile back. And then obviously sepsis over the LP site. So in terms of managing a patient with meningitis, your first step is always your primary survey. I didn't want to go into a hell of a lot of detail with this because I think we all hopefully practice it a lot, and it's all your ABCDEs, and you manage each like derangement as it happens and try stabilize as much as you can in the primary survey. I did want to just state that our NICD guidelines, the same ones from 2019, did suggest that if possible, patients with, they spoke about meningococcal meningitis, but if it's meningitis and you're not sure what, if there is a possibility for isolation, that it's advised, especially respiratory droplet type of isolation, so visors, N95s and gloves and aprons, for at least 24 hours. And in this time, it gives antibiotics the time needed to decrease the nasopharyngeal carriage, which would then be causing the spread. So maybe not suitable in all institutions, but something to consider if possible, especially in meningococcal. The other tenets of management, as I like to summarize in my head, was managing your features and the sequelae of raised intracranial pressure, managing seizures, managing septic shock, and managing specifically for meningitis, so antibiotic therapy, antiviral therapy, etc. So I'm going to touch on ICP very briefly. Like I said, a summary. So managing increased ICP, we all have heard the term neuroprotective measures, and I think we're all quite familiar with it. And if we're not, there's lots of text to kind of go back and check exactly what parameters we're looking for. But the summary here is that you, if needed, intubation, ventilation, sedation and paralysis, managing of your seizures, managing 20 degrees head up. Some texts say 30 degrees head up. Some recent UK texts have shown that have conducted studies that showed 20 degrees is as good, if not better, but I don't know more detail than that, unfortunately. But it is 20 to 30 degrees head up, and then keeping all your kind of basal metabolic rates normal, so normothermic, normotensive, normoglycemic, and then if they have signs of imminent herniation, then to consider hypertonic saline and mannitol. But I think a lot of this I would suggest doing under under guidance from a consultant or the peds doctors or the neurosurgeon. You're going to be co-managing a patient this sick at this point, hopefully. Ultimately, the aims of decreasing your intracranial pressure is to decrease your cerebral metabolic activity. This can also be seen as optimizing your cerebral perfusion pressure. So all these mechanisms on the left will optimize the perfusion pressures in the cerebrum, hopefully to prevent ischemia and secondary injury. So it's transferable to head injuries. It's transferable to status epilepticus and a lot of other pathologies we see in the ED. The next important tenet, I think, is management of seizures. So this is taken from our updated RHEMA protocol, with thanks. And I think we've definitely all come across seizures. We've definitely managed at least the first line therapy, which is benzos, and then ABCDE support as needed. And most children will respond to the first line therapy of benzos only to arrest a seizure. If not, after 10 minutes and still seizing, then you consider your anti-epileptic drugs like phenytoin or phenobarb, or more recently, levetiracetam has become the newer first-line treatment in some places, or epilim. And then if they continue seizing, you try the other anti-epileptic, basically. And then if they're still seizing, you consider RSI, intubation. And then again, at this point, you're discussing with consultants or peds, and you're co-managing as patient this sick. In terms of specific treatment to meningitis, empirically for bacterial meningitis, until you know what the organism is, our guidelines state ceftriaxone 100 milligrams per kilogram per dose daily, and some texts also suggest 50 milligrams per kilogram per dose BD, but so it's the two are transferable. And then they also suggest ampicillin if there's a concern for listeria. In infants less than 3 months old, it's not ceftriaxone, it's cefotaxime, because of the risk of precipitation with ceftriaxone and calcium-containing fluids. There's been shown to be a higher risk in neonates. And then neonates also get ampicillin because of their higher risk of listeria being at an extreme of age. Then once, if you have cultures back and you can target down your antibiotic therapy, then our text suggests, our guidelines suggest benzyl penicillin for Neisseria meningitidis and strep pneumoniae. If it's TB, your TB treatment, and that's for 6 to 9 months, depending on clinical response. Viral would be acyclovir with the drug doses as stated. And then just to touch on fungal and parasitic, amphotericin B plus discussion with ID in peds, because it's not, it is a very toxic drug, as we know, so it's not without a lot of risks. And a kid who needs amphotericin B is probably quite ill otherwise, because CCM wouldn't typically happen in otherwise healthy children. Same with neurocysticercosis, would be in discussion with ID, and that's I didn't go into the doses too much there. It was interesting, and maybe some of the Tammy and anyone else wants to comment on this at the end or now, but I found conflicting data on dexamethasone. So that 2013 paper with some of our colleagues from Rahima, they advised against dexamethasone because they had done a study that showed no improvement no improvement in the long-term sequelae, so like your permanent cranial nerve injuries or cerebral injury by using dexamethasone. It showed no improvement, so they said it's not necessary. But then in our Western Cape guidelines, for instance, and our national guidelines, they do suggest dexamethasone for those more than 2 months old. And the idea is to try and mitigate for all that inflammation and permanent cranial nerve damage and complications. So just something, to think about. Maybe at the end, we can comment on that. And then coming to the complications, as I mentioned, so cranial nerve damage can cause hearing loss, visual issues, language, speech, memory issues, executive function issues, concentration, quite a few, frontal lobe type of features. Can cause seizures and then a resultant epilepsy potentially. And I didn't mention, but I just thought of it also global milestone delay in children, whether global or an isolated fine or gross or motor development. That's something to consider as well. Limb scarring amputation is a specific complication, more speaking towards sepsis and that thromboembolic phenomena that happens more likely with meningococcus. But it can cause such bad scarring and such bad end organ or end limb damage that amputation is necessary, especially in small humans. Obstructive hydrocephalus and the complications thereof. And then, as I mentioned, the not mentioned yet, but vasculitis and thrombophlebitis, which can cause localized ischemia and strokes potentially. And just the last point on prevention, vaccinations, contact precautions, and chemoprophylaxis. So vaccinations, I've mentioned earlier about our EPI and how we've done quite well with our Haemophilus influenza and Streptococcus pneumoniae vaccines, which is on our EPI, all kids hopefully get it at 6, 10, 14 weeks and 6, 14 weeks for the heme influenza and strep pneumonia, respectively. And it's just important to note as well that these are vaccines against the most harmful serotypes. So not that you won't get strep, pneumonia, or hemophilus, but it'll be the idea is that the vaccine will prevent the most severe serotypes. Interestingly, we don't have meningococcus on our EPI, although the NICD guidelines of 2019 do describe meningococcal vaccines that exist, and they cover a couple serotypes, but are not on our EPI. Didn't explain why they're not on the EPI. So if anyone knows, feel free to jump in at the end there as well. But that the meningococcal vaccine is advised for children at risk. So I guess, immunocompromised, or a household that has another child or something. They didn't also elucidate exactly what they mean by at risk. Contact precautions, as I mentioned before, I think we're familiar with that after COVID. It's a respiratory droplet spread illness usually, so the same applies. And then chemoprophylaxis is another big topic in meningitis, especially meningococcal. So in South Africa, we use ciproflox or ceftriaxone for contacts. And then WHO also describes IV penicillin for moms in labor. These guidelines that I've repeated now multiple times describe close contacts should get chemoprophylaxis. And by close, they mean prolonged and close in the preceding 7 days of onset of the disease of the patient in question. They describe close contact as sleeping and living in the same household, kissing, sexual partners, emergency medical services, so your paramedics, and your emergency healthcare workers, so like you and I and ED and the nursing staff. They advise that all of us get prophylaxis if we are in contact with someone with a high concern for meningococcal meningitis. Not indicated is your work school contacts, social function contacts, and public transport contacts. So, if you're in a bus, someone gets a meningococcal, the rest of the passengers don't need chemoprophylaxis. But in practice, a lot of people just take it just in case, because the risk-benefit ratio is obviously in favor of benefit. 500 milligrams of Cipro is not probably going to have any deleterious effects. But also, the last point, very important to remember, that meningococcal category 1 notifiable condition, and Haemophilus B is a category 2 notifiable condition in South Africa. And then just lastly, our take-home points of the presentation, as I kind of understood it, is that meningitis can be very obscure in peds. It's very difficult to diagnose sometimes specifically. And one must have a high index of suspicion in any of these cases with even subtle signs. The medical emergencies related to meningitis, I understand to be shock, seizures, features of raised intracranial pressure, and then any derangement in your ABCDE that's caused by the meningitis is also a medical emergency. Antibiotics are very important. They must be as soon as possible, and ideally after appropriate sampling, but don't delay if you can't get samples, because life does sample. Obviously, there's a waiting towards life and antibiotics soon. Just remember the contraindications to LP, and then manage those appropriately if necessary. And remember as well that there's up to a 30% risk of permanent injury and complications from meningitis, which is quite significant. So even more so to try be astute and have a high index of suspicion and manage these as quick as possible, and with help if you are not sure. Because these children can be quite sick, they need to be managed in a high care setting, and they need to have access to rehab during and after the illness. And yeah, that's the end from me. Thank you so much for listening and watching. And if anyone wants to comment